Hello, everybody. My name is Mike Kopko, and we're very excited to be here with you all today to present some of our findings of our primary care pulse. I am the CEO, co-founder, and board member of Pearl Health, and joining me is our leader of clinical care and EVP of clinical strategy, Cameron Berg. Cameron, do you want to say hello before we kick things off?
Yeah, we're very excited to be here to process a little bit of what we heard from primary care physicians in our Pulse survey, and then give a few takeaways about how we see the intersection of value based care starting to satisfy or solve some of these emerging problems. Really happy to be here today.
Great. Well, I'm going to get into our session, and I know that we're the only thing between you and lunch, so we're excited to walk through what we've got in store for you today, and we'll try to get all of the executive takeaways up front so you can have the best of our report for your benefit. What we'll cover a little bit is state of primary care. We'll share what we learned through our Pulse. This is our second year of doing it. We interview primary care practices across the country and get their kind of real feedback on what it's like to do their job every day. And then we'll talk a little bit about the intersection with value-based care and how that landscape is evolving. A little bit about us just before we jump in. We are a technology enablement company that helps provider groups move into value-based and alternative payment models. We are a pure tech play, so we don't buy or own physicians. We don't build clinics. We enable physician groups to change how they get paid, the information on their patients so they know a lot more about them and can manage them holistically. And we take full risk on lives, much like an insurance entity. And so we have 80,000 lives that we are completely at risk for across 1,800 physicians and have raised a little under $100 million to date from some fantastic investors. So we'll get into a little bit about that later on, but I want to start talking about primary care and the state of it. So healthcare is a $3.4 trillion business. It is growing at a secular level. For folks who are close to it, some of the major trends that we like to point out when you're moving into physician spend and how they can actually move the cost curve, you've got to know where the money goes. So hospital care has been fairly resilient. It's still a very tough profit line for big systems to make money providing these services, but there are a lot of dollars that flow through it. It's still the majority of health, or I should say the plurality of healthcare expenditures. Physician revenues have stayed pretty consistent over a decade. We've got some slides on that a little bit later, but it is the second largest category. Unsurprisingly, drug spend is kind of in third place as its own distinctive category. And as we move into more senior care, that becomes a critical place for folks to pay attention to how to manage total cost of care. And we'll talk a little bit about that later, but that has been something that over the last 10 years has been the fastest growing spend category. Primary care has been fairly resilient with a little bit of exceptions recently. So I think the biggest good and bad about primary care, it's still a fairly sizable line item in total cost of care. It depends a little bit about which population you're talking about. So more is spent in commercial, less unfortunately in Medicare and Medicaid. However, over the last 10 years, it has been declining. COVID obviously accelerated this, but what we've seen is a little bit of a diminished role in primary care influence of healthcare spend. And at some level, we find that concerning because it is typically most often associated with satisfaction of patients and an ability to move holistically into patient care. The inverse of this is the growth of specialty care and other specialty services, which often are quite expensive and many times don't leave the patient feeling healthier, but deliver expensive services to them in a timely fashion because of the fee-for-service business model. So one of the things that we watch out for in the primary care category is the resiliency and frankly, improving the capabilities of primary care so that they can move more longitudinally across patient whole health. And one of the things that we'll see in the survey we'll quickly highlight is when you start doing some high level math of how much is spent on primary care and how many primary care physicians are there, it's a robust amount of expenditures, but the primary care practice doesn't capture all of it. And at a pure dollars level, it has been declining, as our previous slide showed. And so it won't surprise you that in this following slide, most folks who are entering medicine try at least until the last few years to move into specialty care. And the main reason for that, that's where the compensation growth has been. And so what you'll see, at least in the profession of medicine, is a lot more specialists and increasingly fewer internal medicine, primary care, gerontology type specialties that enable a more whole health approach, a more longitudinal, community and panel-based health. And that's concerning for us, and I think for the country, because it implies potentially a rising cost of care without rising satisfaction and necessarily without rising improvements in holistic healthcare. And when you combine that, what we have seen from our pulse is a decline in physicians in the primary care category. And for those who've been tracking this space, this is not news. This is a slower moving trend that continues to move in the wrong direction. I think there are a couple bright spots that I'll highlight today, but we do want to kind of rip the Band-Aid off up front and highlight some of the concerns that our pulse highlights for those who are thinking about the healthcare system of our country and the delivery system that we're all building. The first, we're finding that a lot of folks are thinking about leaving the field, and particularly fewer than half of primary care folks would recommend it as a career. And as any career, forgetting medicine, it's generally not good that those who are in the field today less frequently than 50% recommend it to the next generation. So we think a lot at Pearl on how we change that. I know CMS, CMMI are thinking about how we change that. And I think it is changeable, but we have to get to at least reality first, which is we are not bringing as many people into the field. More people are exiting. And then if you look into some of the consolidation of the category, fewer and fewer primary care practices are sustainable independently now. And so it is a challenging time to think about going into primary care without tools in value and tools in enablement. And so as we think about that shift to value, I think it is kind of one of the first bright lights that is starting to shift the landscape. And I'll tell you, and in my career, I started working at Oscar Health back in 2013. So I've been doing network building and working with physicians for a decade plus now. 2017, 2018 to me felt like the actual low. And I think over the last couple of years, there's been some bright spots. The reality is physicians are most tied to satisfaction of patients, and primary care investments are most academically linked to reduction in total cost of care. Being proactive and preventative is the best way to manage a population. And I think the shift to value creates an opportunity for change. So what we think about is the policy landscape. For those who are not as close to it, CMMI and CMS, the innovation and respective largest organization of the federal government that manages our healthcare, have made policy decrees that they want to create accountability of care across all of Medicare by the end of this decade. And what that means in short is that the compensation model and the incentive model will fundamentally change. Increasingly, you will get paid less, relatively speaking, to provide services in like a point of care type mindset or a visit type mindset. And more of the opportunity economically and frankly, population health and intelligence wise will come from signing on to be responsible for the patient's total cost of care and total health. And we think this is a welcomed and positive direction. And what I think has been done most strikingly is that they have given to primary care the first right to convert to these models. So if you're a primary care practitioner out there, you have a property right, an economic one. I want to be very clear on words here, but you have an option to convert into this model and not an obligation, and claim and move over your Medicare patients and have them attributed to you. So this does not go to a specialist, this does not go to a hospital, does not go to an insurance company, it does not go to a bureaucrat, it does not go to a business person, it goes to a primary care practitioner. That property right, again, in an economic sense, I mean it like a contractual right, not like you have a property right of a person. That contractual right is worth real dollars today. And so we can talk after this and you can always follow up with us directly. But what we've seen in the last few years, that right has changed compensation for primary care, and it will bring online a tremendous amount of information and intelligence about your patients that only you have that first option to. Physicians generally like this rotation, this movement to accountable care, and they increasingly feel like it recognizes their contribution. And so I think one of the biggest problems, if you looked at the chart prior, and I'll just jump back for a quick second, the biggest problems in this 6% chart is if you actually improve someone's whole health and you're now at a world where you're getting slightly above 3% of the reimbursement, there's a mismatch there. And accountable care creates a very different prospect, because if you can influence that total cost of care, you can capture some of those benefits. So we're starting to see that bright light emerge in our surveys. It's still small. It is still something you have to look for, but I think it shows a changing of the future in physicians' attitudes and approaches. I think, some of this we spend time just talking with primary care, so we want to kind of highlight and give a voice to folks who participate in our survey. But Dr. Bitsas from Family Medicine and Monroe Family Health Center wanted to share that primary care is becoming more front and center. But what really makes a difference is who gets to call the shots. And I don't know that model is moving towards doctors calling the shots. So this kind of shows, and why we're seeing this policy shift, a move so that physicians, and in particular primary care, can move into that position. And I worked with primary care for a long time, so you probably, as you're hearing this, have some jaded thoughts around, I've heard this before and what's different. And what I can tell you, having seen all of the different interactions with the 80,000 practices that are independent primary care across the country, you have an opportunity now to negotiate and position your practice very differently than you did because of the models that have been given. And so while, to Dr. Bitsas' point, I still think there are some things that need to be proven out. The opportunity for the primary care practice to capture this moment is more real than ever. Okay, so I'm going to kind of walk into our pulse a little bit. And we love kind of just doing these surveys and lighting it up. What we try to do is basically come to what is the state of primary care in the country today? What are challenges, impediments, and frustrations, and what are opportunities? We interviewed 202 physicians nationwide. Some of these are done online, phone calls. We offer incentives so that people are compensated for their time. And so we were really just trying to echo the voice of the primary care. This report is available on our website, pearlhealth.com. It's free to you, and we're happy to do any follow-ons. We love doing it because I think primary care doesn't get enough of a voice in this country. And so every year we plan on how do we amplify the microphone, if you will. And so we've made a major turn from last year, and we're excited about another major turn next year. Okay, so compensation and payment models, something that, having worked with primary care, sometimes I think folks are a little bit shy, embarrassed, uncomfortable talking about it, but I think it's important. And it's important to have these conversations, I know, in your day-to-day when you're contracting and working with payers, but we think it's important to interview and survey around it because it does effectively reflect the resources that we all plan and allocate to primary care in our country. And we are concerned that it's not sufficient. And so some of our survey will highlight that a little bit, but to give some voice to Dr. Mathwich from Family Medicine Ascent Medical Group. For too long, primary care physicians have been paid for the number of patients seen per day rather than the quality of care provided, resulting in poor outcomes, unhappy patients, and physician burnout. So one of the concerns that we've had as we've built this community up over time is this mindset of how many patients I have to see to generate the economic outcomes that keep the lights on in my office. And I've talked directly with physicians. These numbers approach 20 and 30 patients per day. And everyone knows that that is a very difficult clinical model to not only address health concerns, but frankly, to enrich and grow the primary care physicians that power it. That continuous context switching and limited amount of time creates kind of a transactional, almost assembly line experience. And so one of the things that we're very excited about as the world considers a more forceful rotation of value is actually fewer patients with more time being solved at root, and frankly, more economics available to primary care as they do it. So one of the things that we know is the backdrop to this is a money model that has not recognized what primary care is good at and how it should be recognized. So examples from our survey of 200 primary care physicians, only 1 in 5 or 21% feel they're compensated fairly. The charts we've shown makes a ton of sense why folks feel that way. 3 in 10 believe their pay allows them to provide holistic patient care. Unsurprising, most codes that generate revenues are often not aligned with what the patient needs in the office at the moment that day. And then half of PCPs agree that their pay is aligned with improving patient health. And so I think that is kind of that sign of hope and bright light starting to shine through. We can move more of these payment models over time to recognizing where value is created and then how do we compensate for it. So most of the folks in our survey believe value shows promise. And again, I'm sure there are folks in the audience today who are having skepticism of that, and you should. I've been in healthcare a while. I've heard lots of different payment models, lots of newfangled things, and what really changes. But I will also ask you to have an open mind because more of your colleagues see this today. I will tell you, working with the 300 practices we do and the ones that we try to win over, they are getting offered distinctively different incentives today than 3 years ago to join value-based models. A lot of that money guaranteed upfront. A lot of those incentives very clear and very achievable. And I know there are still bad stories to every one of these switches, 2 steps forward and 1 back, but I'm seeing more and more value, at least recognizing primary care differently. And I think that's a real bright spot. So only 56% more likely to believe that they are compensated fairly when they're in a value-based program. 15% more likely to believe that the way they are paid allows them to provide holistic care. I think there's work to be done there. I think that's the rightful kind of skepticism, still saying, hey, I believe it's possible, but I'm not seeing it yet. And then 6% more likely to believe that the way they are paid is aligned with improving outcomes. So we're tilting the scale, but it's not clear to me yet that we have tipped it over. So I think it's something everyone's watching. It's got promise, but there are some things to still be mindful of. With that, I'm going to pass it over to Dr. Berg, who's going to walk you through a little bit about value-based care adoption that he's seen.
Thanks so much, Mike. That was a outstanding, I think, framing of the current position, the problem set, and then a few of those glimmers of the emerging bright lights of value-based care as a potential solution. And I think Mike and I have been around for long enough to be honest about this and say, we've seen similar efforts over the last decade. Sometimes they work, sometimes they don't. They are not without challenges, but what we're seeing, I think, this year in December of 2023 is materially different than what we've seen in previous years, and we'd like to elaborate on that for just a little bit. So if you jump to the next slide, you'll see now that more than half of the PCPs we're surveying are participating in value-based care, and this is a big deal. So there's quite a bit of emerging experience and exposure. The majority of doctors have experienced value-based care in some fashion. As you can see, 3 in 10 of our PCPs are participating in the Medicare Shared Savings Program, or MSSP. And then about 1 in 5, nearly 20%, are in ACO REACH. And we'll dig into that a little bit more in the coming slides. But importantly, we're also seeing that PCPs are participating in this value landscape outside of CMS's structured offerings, with half of them actually participating in value-based care programs through commercial payers. So as we contemplate the enablement that primary care physicians need to succeed in this, it's increasingly important that we think through all of these different patient populations that classically otherwise tend to get siloed in one payer vertical versus another, and bring a solution set to bear that will work equally well for Medicare, Medicaid, and commercial patient populations. Now, as we teased in that previous slide, we really are seeing a substantial uptick in reach. And we'd like to just pause for a moment and elaborate on why we think that's happening. I think value-based care over the last decade or so has been challenged by some false starts. And a lot of times that has come with ideologic alignment. It is the right thing to do to take care of patients efficiently and to think about the impact of these dollars on a system level. But accomplishing that on an actual programmatic level can be really hard. And the initial efforts tended to weight process metrics. We called these quality measures, right? And we came up with a lot of different incentives for doing process metrics to ostensibly better patients' health. I think if we're being honest now, as we've reflected on the implementation of those programs in the real world over a few years, we've seen many times that these quality metrics are not actually associated with the population health outcomes that we were hoping to see. And primary care physicians see right through that. They see through it early on. And because of that, they've become a little bit more interested in REACH. So as a bit of background, REACH has been around just since January of 2023. It was, of course, announced back in 2022, but we're really only in the first year of full REACH operational care. And it differs from pre-existing programs in a few different important ways. First of all, it is paying primary care physicians prospectively. And that is a non-trivial benefit for PCPs. As Mike indicated in the opening slides, PCPs are in a tough financial landscape right now. And if they're literally needing to wait something like 6 quarters to get paid for the work that they're doing and for the investments they're making on a practice level, that can be quite challenging. Prospective payments move that needle. There is much less in the way of administrative work required by REACH insofar as there are very few quality metrics. And we really are just trying to keep patients at their best quality of life for the lowest cost. And there's no minimum savings rate. So that has also challenged pre-existing programs here by telling primary care physicians, hey, you've got to get over this gate. And then once you cross the gate, you're in the running for savings. What happens with REACH is, of course, even the first dollar can be saved. And then finally, on the alignment level, we have seen many challenges with purely claims-based alignment. And what REACH allows is for voluntary alignment, wherein you go to your physician and you jointly indicate to CMS, of course, the payer here, that Dr. Jones is my doctor, and therefore Dr. Jones should receive the benchmark for my population health. If you jump to the next slide, you'll see a really great quote from Liz Fowler, from CMMI, who is creating these programs. And what I would like to just reflect on is we're seeing some really innovative work come out of CMMI. We gave you some of the details of ACO REACH, but very similar programmatic elements are being inculcated in Making Care Primary, or what is referred to as MCP, and also the Guiding and Improved Dementia Experience, or the GUIDE model, which is complementary with other shared savings models and is focused entirely on value-based outcomes in a dementia subpopulation. And from Pearl's perspective, we're really heartened to see the investment and innovation that's occurring in this space. But that's not to say that we are without our barriers. And there are still some fairly entrenched barriers to the broader implementation of value-based care. And we would like to just pause and reflect on what our primary care physicians told us in their pulse survey with respect to these workflows. So as you see here, primary care physicians generally feel relatively positive about the quality and cost of care that they provide, but it's a little bit of the tale of two cities. Most of the primary care physicians surveyed feel equipped, but a sizable minority, in fact, nearly 40% in both of these questions, do not. And as you can see, something like 1/2 of those dissenters also are strongly disagreeing, and which is a very powerful signal to us that at least 2 in 10 PCPs out there need a materially different information layer before they can pivot and deliver on value-based care outcomes. And what we see, I think, when we ask to dig a little bit deeper about the challenges, is a few very telling stories. So when primary care physicians are existing in 2 pools, right, they're trying to maintain the efficiency of that 20 to 30 patients that they're seeing on a daily basis in order that they can collect enough claims-based revenue, that they can make the investment to keep their practice going. And what all that means is we're functionally telling doctors, hey, you should do 27 hours of work in a 24-hour day. I think none of us get paid to do 27 hours of work, PCPs in particular. And what we have seen from a very, very powerful publication here is if you just try to inculcate the very accurate guidelines that are out there into your clinical practice, you're going to be challenged because you do not have enough resource to make that work in the fee-for-service construct. There simply are not enough hours in the day. And then one of the other big promises has been, hey, The information age is here, and digital health is here, and all of the EHRs can be doing some of this segmentation and calculation for us. And I think as we have seen, sometimes that works and other times it doesn't. The information landscape here really depends on your EHR, how you implement it, how you integrate it, and how you continue to iterate on it after it goes into effect. But what we saw loud and clear from our survey is that half of primary care physicians are feeling that EHRs are actually detracting from their clinical effectiveness. And this has been corroborated in large peer-reviewed publications that have come out this year. Out of Stanford, for example, nearly half of doctors feel that the EHR, which is for us, the information layer, is actively working against them as they try to pivot towards value-based care delivery. Pausing for just a moment, we wanted to give a little bit of opportunity for Dr. Justin Porter, who is the author of that first 27-hour-day trial. And he says there's a sort of disconnect between the care we've been trained to give and the constraints of a clinic workday. We have an ever-increasing set of guidelines, but clinic slots have not increased proportionately. And that is one of the big challenges from primary care physicians that are trying to live in this dichotomous landscape of value-based care, sometimes fee-for-service, other times, and then the reality that they have of a single care delivery and a single operational platform being constrained by those dual priorities. So what do? We do think that there's a path forward here, and a lot of it comes from enabling PCPs with the right sources of actionable, interoperable information. This has been a long-standing promise in the information ecosystem, and it's our belief that we're getting very close, indeed, that we can offer this to many primary care physicians. And what does that mean? It means a platform that is easier to use, that will allow you to go from that reactive waiting room to a proactive panel management. And sometimes that means that you're prioritizing patients who are not in the waiting room, who need a telephone call or a touch point that won't ever result in a billable or reimbursable claim. But by reaching out to that patient in their time of need, you are avoiding the kind of very high cost events that occur in our system when somebody is admitted to the hospital or calls 911 and goes to the emergency department or has duplicated care delivered from a specialist or an urgent care. We think that the platform should be simple and that it should give you a holistic view of a patient journey that exists outside of your EHR. So despite all of the promises of EHR interoperability, we've seen that oftentimes they come with the construction of walls. And those silos need to be broken down in order for PCPs to respond to real-time, high-value information signals. And sometimes that means delegating this commodity information to somebody else who can collect this on your behalf. And then finally, it's all about distilling these down into actionable insights. I think we all know, and we all have experienced lots of retrospective analyses, the kinds of things that say, hey, Dr. Smith, do you know that your diabetes patients have A1Cs that are trending too high? Maybe next year when you see that patient for a preventive visit, you should do something about that. Well, while that might move the needle for the patient next year, what's very different is reaching out to prevent the development of this pathology to begin with. And we really do believe that these new programs are starting to give some capitated revenue that will allow PCPs to retain more of the value from these otherwise unpaid actions that they have historically invested in. So here's one more quote from one of Pearl's provider partners to leave you with before we wrap up. Dr. David Lamond, who's the chief executive and medical director of Blue Sky MD, says, the future of healthcare is exciting, and we're seeing this pivotal change. We're starting to think about value and quality at the same time, which is a unique thing from previous iterations of healthcare. And from where we sit, it's very heartening to see primary care physicians confronted with this problem space, but feeling like they have a new tool in their toolbox to address this emerging opportunity of value-based care. Thank you so much for having us today. We hope that the rest of the conference continues to be stimulating, that you have a great lunch. I know Mike and I would both welcome any further dialogue. If something we've said today piques your interest, if you want to dig a little bit deeper into value-based care enablement, please reach out directly. You see our emails up on the slides, and we look forward to taking the conversation from there.